during the winter time, we have a little frequent, idiopathic epistaxis. And from when I was in New York as well as in Boston, we, have a few cases of the winter time to have intractable epistaxis. Patient comes in with a packing usually, okay, bleeding all over, and you can see it in this patient with the bilateral packing, and still some of the bleeding coming from even with through the eye. How we get the bleeding from eye? Anybody knows? No, packing usually not complete, usually incomplete. So there's bleeding coming from usually posterior nasal cavity going through nasolacrimal duct, and then you can have bleeding coming, looks like coming from the eye. For epistaxis, more often we see this idiopathic. We don't know the reason why. Probably associated with hypertension and other arteriosclerotic diseases. And these are the possible, causes of epistaxis. Okay, you're probably familiar very well. And even though this was a very old publication, it shows majority of idiopathic or majority of posterior epistaxis are coming from unknown origin, okay? Usually associated with other vascular diseases of the patient. They usually have hypertension or other vascular disease or diabetes are so-called predisposing factors of this idiopathic epistaxis. Usually, majority of the patients are treated as, ENT surgeons and by nasal packing or arterial ligations. And this was, they went through the Medicare patient database, okay, and they found out, this inpatient recordings of pretty almost 10,000 patients. And they find that only 2% of those patients, 2% of those patients were treated by endovascular route. Okay? And those are, usually intractable by nasal packing or continued bleeding in spite of the proper nasal packing. Those patients comes to our service. Okay? Before we talk about how we do the embolization, we have to know the details anatomy. We discussed already. The majority of vascular supply in nasal cavity comes from the sphenopalatine artery. Okay, we'll see a little bit. But possibility of the collateral supply or major supply can come from descending palatine or accessory major artery. Accessory major artery do have blood supply to nasopharynx. Okay? Nasopharynx, which can be dominant, I showed you yesterday. Other pharyngeal trunk of ascending pharyngeal artery can reach nasal cavity, especially posterior nasal cavity. And facial artery can give ala branch, okay, ascending palatine or ala branch. Ala branch usually reaches anterior nasal cavity or mid-turbinate region is supplied by the ascending, facial artery which go through the ala branches. Okay. There's a typical angiographic feature of distal internal maxillary artery. You can see the sphenopalatine artery. Sphenopalatine artery divides into two branches, okay? Turbinate branch and septal branch, okay? The other branch you are seeing is a descending palatine artery. Okay? Descending palatine artery is ENT surgeons call the greater palatine artery. That's a descending palatine artery runs right behind the maxillary antrium. Between the maxillary antrium and palatine plates, okay, there's a small hole. It reaches down to inferior soft palate as well as hard palate region is filled from this descending palatine artery. You have to remember there's a possibility coming from ethmoidal artery of the ophthalmic artery. There's a certain possibility it can come dominant supply to the anterior and mid-nasal cavity areas. This is the patient who had a sphenopalatine artery, but majority of the septum is supplied by ophthalmic artery to ethmoidal and to the nasal cavities this way. Okay, this is again example of the dominant supply can come from other branches, such as this is what? Infraorbital artery. Its infraorbital artery is right below floor of the orbit. There's a small, tiny canal, which is a V2 division of the trigeminal artery runs with the infraorbital artery. You know the blowout fracture? Blowout fracture is where the infraorbital canal is fractured because a very thin bone is covering that one, okay? So this is a good example of the infraorbital is dominant supply to the nasal cavity as well, okay? And this again showing example of ascending palatine artery is dominantly supplying inferior turbinate and mid-turbinate region from the ascending palatine artery. This is ascending palatine artery. Sometimes facial artery as ala branch can reach there, okay? This is the example of the accessory meningeal artery. Accessory meningeal artery is reaching. This is actually the patient had arteriovenous malformation. This show you example of accessory meningeal artery can give supply to the nasal cavity through the nasal branches. Okay. This is again typically a supply coming from the sphenopalatine artery, septal branch, and as well as turbinate branches, and this one. Even though a patient has continuous bleeding, okay, continuous bleeding in spite of the packing, when you see the patient, they actually, in my career, only one case I've seen the active extravasation on angiography. Okay? This is the only case I saw active extravasation. You can see extravasation and going to the posterior nasopharynx and going to the oral cavity in this way. This is the only case I've seen active bleeding, even though patient continued to bleed. So what you do is when you go for the embolization, you go for the more of a territorial embolization rather than active point of the embolization. Okay? Usually before, the ENT surgeons usually go to the the internal maxillary artery clippings. They go into these nasopharyngeal fossa, they see whatever, either vein or the arteries, and they usually clip whatever they see it. That was the treatment of the choice all days before development of the endovascular treatment as well. Okay? So there could be a failure of the IMA clipping is due to the incomplete clipping or alternative dominant arterial supply. As I showed you, there were several different arteries can dominantly supply the nasal cavity. Excuse me. Or in spite of the proper IMA clipping, it could be collateral circulation developed immediately after clipping. That may be cause of a failure of the clipping of those. We published in 1989 why it fails. This is one of those cases, failed the clipping. You can see the clip is there, but you missed the main trunk of the sphenopalatine artery, and sphenopalatine artery is continuously filling this way. This is again the dominant supply coming from the descending palatine artery, and the midpharyngeal artery going to descending palatine artery and reconstituting area of the clipped territories. Okay, so endoscopic approaches give a better chance of proper clipping of this sphenopalatine artery trunk. And with the clipping of the sphenopalatine artery trunk and with the packing, it helps to stop the nasopharyngeal bleedings. We used to have protocols. Patient comes in with the refractory epistaxis. Usually they go to posterior packing. Anterior packing doesn't do anything. Okay? So posterior packing, proper posterior packing with, they have this now. They used to have a Foley catheter, inflated, but they have now newer packing system. And in spite of the proper packing, if it has a recurrence, we go to the embolization. Okay, if we are not available, they have a sphenoparatine artery. In case embolization fails, patient goes to ethmoidal artery ligations because of the reconstitution of the especially septal branches going through the ethmoidal arteries. So we do a proper evaluation after the embolization when patient has a recurrence of the epistaxis. Angiographic protocol, we always ask a surgeon, ENT surgeon who put the packing in, which side do you think it's bleeding from? Often they don't know which side is bleeding, so it's actively bleeding. Okay? So in case we know information, we go ipsilateral side, certainly go to the internal carotid artery to evaluate other pathologies, okay? Whether internal carotid artery has some problems or, okay, and the significant collateral is existing or not, okay? Then we go to the internal maxillary artery specifically. We go with the microcatheter and we embolize ipsilateral internal maxillary, especially sphenoparatine artery. Then we go for the facial artery. Facial artery has a significant supply. We do use a larger particle to just to disconnect any supplies. And then we go to contralateral. We always do bilateral sphenoparatine artery embolizations, always, okay? And even in one side epistaxis, there's a good possibility you may have, the collateral circulation comes from a contralateral side. Materials, we always PVA particles, polyvinyl alcohol particles, okay? I usually use a 150 to 250 micron in size. In case there is any significant collaterals or large enough collaterals, then we change to 250 to 350 micron or 250 to 500 micron size. Last, after the proper embolization of distal branches, you block it with gel foam, okay, strip of gel foam, okay? I call it gel foam torpedo. You cut it down to small pieces of torpedo and you compress it, and you can load it into the microcatheter with the 1 cc syringes. This is very, this is larger than lumen of microcatheter itself, so you have to force to load it and push it with the 1 cc syringes so you can do a blocking. Okay? We don't use it either glue or we don't use it coils. Okay? That if you use it coils or if you use it glue, you are closing your door behind it. You cannot get back in case patient has recurrent epistaxis. This is one of those that you can see. You don't see much of the stain of the turbinate because of packing. Okay? And so we go for the territorial embolization. Okay? This was embolized bilateral. And also there is some supply coming from the facial artery. Okay? The facial artery was also embolized with this larger particles. This is again contralateral side, nothing specific about it. You have to be careful not to get reflux. You also watch it, collateral circulation to the orbit. Okay? Ophthalmic artery, you always have to watch it. And we try to go into the distal branch of the descending palatine as well. You can see the sphenoparatine artery supply is completely eliminated. And even if you close off, okay, if you use the particles, you don't get the necrosis. I have only 2 cases developed the necrosis of the ala of the nose, not because of this embolization, because of the nasal packing was there so long, so you have necrosis of ala, not because of the embolization per se. Okay? So this was kind of procedure you can go through. And if this is ascending palatine artery's dominant supply, then you can go into that. Okay? Post-embolization, we keep intubated. Okay? In case you don't see any significant, good embolization, then under general anesthesia you remove packing. Okay? You remove packing, but if your patient has continued bleeding, then you repacking and re-embolize. Okay? And sometimes we wait, if it's usually at night, and at night it's difficult to control the bleeding and have a, experienced surgeon available. So we may wait until next morning to remove the packing, okay? And in case you have a ethmoidal artery supply to the septum, and then you send for the ligation of ethmoidal arteries. The surgeons do very well with the ligation of ethmoidal artery. They just go to medial canthus and expose the ethmoid and ligate the vessels which goes there. Both anterior and posterior ethmoidal arteries can be easily clipped by surgery. Okay, so this was patient had recurrence, so we went back in again, and we embolized because of the little stain in the mid-turbinate. So that was properly embolized. Okay, and one more thing I like to stress is you have to remember anastomosis with ophthalmic artery. Okay, I mentioned details about ethmoidal anastomosis and also other anastomosis, either anterior deep temporal artery or middle major artery can have anastomosis with ophthalmic artery. Those things you have to watch it and try not to make any significant refluxes to get into the middle major artery. After the embolization, we always do the CT or MRI to see any pathology available, pathology persisting, okay? To rule out any major pathology of either internal carotid artery or cavernous sinus. Okay, so these are the patients usually have, because of the persistent few days of the packing, you may have accumulation of secretion in the maxillary sinus, or this is frontal sinus. Patient had chronic sinusitis on these regions, so those ones has to be evaluated after the embolization. Okay, these are those results. It's not very important. This is old result. I'm sorry to show you, but this is showing you this relatively good result of endovascular treatment of this intractable epistaxis. Okay, there is one necrosis of ala of nose and one necrosis of oral mucosa. There's two complications we experienced in early days of the embolization. I think Carla will talk about more details of HST. I'm not going to say much about it because of the AV shunt kind of exist in nasal cavity. The only comment I like making is that you know, for HST patient, we do have we use larger particles. Okay, usually 250 to 350 or 500 micron size embolizations. And also, you have to remember, patient with HST can have pulmonary AV fistulas. Okay, so you try to get into the veins, okay? Not to get into the veins with the embolic materials to prevent any inadvertent stroke of the patient with HST. Okay. Some other causes of epistaxis, I'm going to show you a few examples. This is patient, an old patient. You can see these, old angiograms, old the cut film angiograms. Patient was treated, fell in San Francisco area cliff to try to catch his dog, and he had a skull fractures, and he developed this carotid cavernous fistula. He was treated in UC San Francisco. Fistula was closed, and he came back to the New Jersey where he lived, and occasionally he get this massive epistaxis. Massive epistaxis, and then he goes to hospital and get a couple of units of transfusion and go home. They didn't have any details examination until he had a few episodes of this epistaxis. So after further workup, what we found is this is what? Pseudoaneurysm from carotid cavernous fistula, and the recurrent pseudoaneurysm like this. This was rupturing into the sphenoid sinus and causing the epistaxis. Okay? Then bleed stops. That's what had happened to this patient. And this is we had to close off this internal carotid artery with the detection of those days. Even though this is old case, it's interesting. This patient had car accident, and they took a skull X-ray. They saw this large cellar. So it turned out to be he had a chromophobadenoma pituitary gland, and he was sent for transsphenoidal surgery of this pituitary tumor. And during the surgery, they have massive bleeding, and they packed it and they sent it to us. And when we did the angiogram, this is what we have. This is patient had. You can see here where the surgeon went in. You see, this is not went into the midline, they went to the sideways, okay? They removed the portion of the bone and they had removed part of carotid artery massive. Okay, this was then treated with a complete occlusion of the internal carotid artery. This is the case I showed you. Aberrant carotid artery. He had a biopsy through the ear, okay, and he developed this pseudoaneurysm. We had to close the carotid artery with the detached balloons this way, okay. This is the last case I'm going to show you, okay. This is a very interesting experience I had. Patient had the same thing, underwent pituitary surgery to a transsphenoidal by a very experienced neurosurgeon, okay? And then, while he was with me, he had a massive hemorrhage again. He packed it and sent it to us. This is angiogram what we have at the time, okay? What do we have? Carotid artery, AP and lateral view. He had a little biopsy of the carotid artery, and this is pseudoaneurysm. Okay? It was a so narrow neck, okay, narrow spot that is filling this pseudoaneurysm. I thought if I put the packing this spot, it would close off. Okay, I don't want to put the stent or I don't want to put anything. I just want to, because of the so narrow, okay, neck. So I put it in a coils. I closed up 3 years later. You see the closure. There's a little spot remaining. Okay. But it's after 3 years, I thought that this is healed. Okay? Patient, this is follow-up, okay? There's a little change of the shape, okay? And patient was continuously from the yearly, we just take a skull x-ray to see any changes, and we had an MRI. This is 7 years after MRI. This is quite stable, nothing happens, okay? This was a patient had gain follow-up, okay? Then she was fine, and this almost 8 years. The patient went to the Pennsylvania somewhere and visiting her family, and then she coughed a lot, okay, a few times. Then she felt something in the nose. So she started pulling out the things she caught it. This is what she pulled out. Okay, this is I think the dime. The dime is about a centimeter, and U.S. dime is about a centimeter diameter. You can see how much she pulled out. So what I had to do is I had to go with the ENT surgeon, clean up, and see what's happening. And this is after the cleanup of all the coils, and we did an angiogram. She has been stable for this. Okay. So this was a pretty bad experience I had with her. Okay. We have time. Maybe I'll show you one more case. This is a patient who had a Laffour type 1 procedure. You know what it is, Laffour type 1? They cut through this maxillary ridge and then pull out surgery. And after the surgery, she had a massive epistaxis and bleeding, and this was what happened. Okay, they went through this, blade, and apparently they damaged the internal maxillary artery that was bleeding so massively. So I had to close it off, that internal maxillary artery with detachable coils. Okay? So there's an unusual type of epistaxis I experienced. Okay? So idiopathic epistaxis is using particles. Don't close the door behind it, and always coordinate with the ENT surgeons to control bleeding properly. Okay? Thank you very much. Any questions?